further ado, Sarah.
Thanks, Rick. Good afternoon, everybody. My name is Sarah Dugan. I'm a mental health pharmacist. I'm faculty here at Neomed. And as Rick mentioned, our topic for today is adverse effects and contraindications. Rick, can you give me a thumbs up if you can see the slides? Excellent. Thank you. Thank you. So our objectives for, I said afternoon, we're still in the last little bit of the morning. For this morning are to define adverse effects and contraindications. We're going to look at some common ones for 3 different medication classes. So antidepressants, antipsychotics, and some of the mood stabilizing medicines. I picked these because they tend to be some of the classes that are most commonly brought up in the cases that are presented here. And then we're going to look at contraindications for these 3 classes as well. For full disclosure, I could take one of these classes of medications and do only information on adverse effects or on contraindications. So this is definitely going to be a high-level overview. Since we can't be completely inclusive, I wanted to make sure that I let you know that complete disclosure, we're not going to be able to cover everything. For the adverse effects, what I did was I selected adverse effects that are reported at least 10% of the time in the literature. So looking at 2 different tertiary resources, making sure that these were the ones that were considered most common, and then identifying some of the more rare but potentially serious adverse effects we can get with these medicines. So those are the ones we're going to talk about today. So to start off with, our definitions. So an adverse effect is a harmful or abnormal result. So something that we didn't intend to happen that could potentially be detrimental. Sometimes it can be a good thing. So if we have a patient that has anxiety and we put them on an anxiety medicine and they haven't been sleeping and that medicine makes them sleepy, sometimes that's a good thing. But we're really focused a little bit more on the adverse effects today that maybe make people uncomfortable. There are a couple considerations for side effects. So how severe is it? It tends to be categorized as mild, moderate, or severe. And then is this something that happens acutely right away, something that we see immediately, or something that happens later on? More with chronic administration, we don't see it for months or longer down the line. And we're going to talk a little bit about both of those. On the other side, contraindications, the second half of the talk, is a factor that renders the administration of a drug inadvisable. So a contraindication would be, an indication is why we would use it. Contraindication is why we don't use a particular medicine. And there are 2 different categories here. One is an absolute contraindication. We should not be using this medicine in this patient, period. The others are relative contraindications. So maybe there's a situation where we could use this, but it would have to be done with really extreme caution. We'll see both of those later today. So we're going to start today looking at the adverse effects. So this was the cycle that we used last week, but we're really focused on the pharmacodynamics. So what the drug does to the body, and it can do 2 things. It can have a therapeutic effect, what we want it to do, but it can also have the side effects, those adverse effects, and that's really what we're going to focus on today. So for our 3 different medication classes, I am not able in this period of time to cover all of them. So I wanted to take a few different types of medications in each class. So for our antidepressants, bupropion is an antidepressant. It's a little unique compared to some of the other medicines, so I wanted to include it there because it has some different considerations. Our fluoxetine and sertraline have popped up quite a bit recently, and those are both selective serotonin reuptake inhibitors, so they belong to the same class. They're like cousins. And then our venlafaxine works a little bit different. It's closely related to the fluoxetine and sertraline, but a little different, so it gives you a bit of variety. For the antipsychotics, same thing. I selected 4 different ones that may work a little bit different. The haloperidol I threw in there because we do see it occasionally. It happens that it shows up in the medication profile or the historical medication profile the patient will talk about today. So that's one of what's considered the 1st generation agents. Many of the individuals that we see now are treated with the second generation, and these are just 3 different medicines, the Abilify, the Seroquel, the Risperdal, that look a little bit different, so it gives us an opportunity to look at some of the differences there. And then for the mood stabilizers, these are medicines that can also be used for different things, including seizure disorders. So I selected 4 of those as well to be able to look at some differences for them. So we're going to do this a little bit different. So Molly, the names are all names of dogs in my neighborhood, for the record. So Molly's a 14-year-old female. She has severe major depressive disorder. She's been in therapy, she's been doing a whole bunch of things, but her symptoms have just progressed and they've decided it's time to start her on an antidepressant. So what might Molly and her family expect? Well, there are a handful of side effects that we can see with most of the antidepressant medications, or a large number of them. Gastrointestinal effects, that's our GI bucket at the top. That tends to happen really commonly with most medications. So a lot of our antidepressants work on serotonin. Serotonin plays a role with appetite. So sometimes we can see their appetite goes down. Sometimes they can get really nauseous. Sometimes there's vomiting. We can see problems with either constipation or diarrhea. So as she's starting it, sometimes it could be helpful to take that medicine with food if it upsets her stomach. If she takes it when she's eaten a decent sized meal, that might be able to kind of help protect a little bit from that nausea. And if she then loses her appetite and has the anorexia, if she's already eaten, maybe that'll diminish that effect a little bit. This is something that patients tend to develop a tolerance to. So once they've been taking the medicine for a little bit, then they're able to, these side effects tend to go away and they don't continue to have them. But sometimes they're really difficult and some patients aren't able to continue just because that nausea or vomiting or diarrhea is so intense. Other effects that it can have are in the central nervous system, so the CNS, our second bucket. Quite a few of our antidepressants actually can cause increased anxiety when you first start taking them. That can look like agitation, that can look like anxiety, irritability sometimes is how that's described. So they may have a little bit more of an edge to them when they first start taking their medication. If we start at a low dose, we can try to keep that in check and then slowly increase the dose so that they can tolerate it. Patients can also get dizzy and it can impact their sleep. Serotonin plays a role with sleep, and again, that one can go in either direction. If it makes them sleepy, let's take the medicine at bedtime. If it keeps them up, then let's take it first thing in the morning. And maybe those concentrations are wearing off right around bedtime and it won't have as much of an impact. Again, many of these often go away as patients are, once they've been taking the medicine for a period of time. So getting through that first couple weeks to a month can be really important, especially because they may not see the benefit for anxiety or for depression. Some of the more serious side effects, the entire antidepressant class does carry a warning for increased suicidal ideation. So checking in those first couple weeks, if the patient is experiencing suicidal thoughts, if they're really kind of dwelling on the thought of death, those would be the times that we want to check in. It's most common when we first start the medicine or if we increase the dose of that medicine. Now, that's something that can be really difficult for a family to understand, that this might cause my daughter, Molly, to have suicidal thoughts, but it's supposed to help with her depression, and maybe suicidal thoughts are part of her depression. Once it helps with those symptoms, we can see those suicidal thoughts go away, but that may take a couple months to get there. So that's why it's important that we're checking in the first couple months. Another couple serious side effects that happen mainly with medicines that are like Prozac, that are like Zoloft, Paxil, Effexor, those serotonin-focused medicines, they have been reported to cause heart arrhythmias. This may not happen right away. So it would be something if they feel any new symptoms, palpitations, or they get really lightheaded, especially if they're getting up, or while they're exercising or out playing, that would be important to communicate. In serotonin syndrome, so if we increase the serotonin in the brain, sometimes there is a threshold where there's just too much there. And in those cases, the patient might end up looking agitated or confused. They might break out in a sweat and have some motor problems. Any of those type symptoms, they need to seek some medical care right away. Each of the medicines can cause some of their own side effects. The sertraline goes in the category with the fluoxetine, but it squinched down all of the text and made it little. So that's where it'll go, is in that middle bucket. So our bupropion, that's our Wellbutrin, that one works a little bit differently. Patients who take that actually can have some weight loss, potentially some blurred vision. We can see an increase in their heart rate when they take it. Many of these, again, can wear off. The weight loss may be continued. So buproprion's part of a couple weight loss medicines. So we might see their weight starting to go down. So if a patient is barely at a normal weight, they're really underweight, this would be a consideration for them, because that's not a side effect that's likely to go away. For our serotonin-focused medicines like the Prozac or the Zoloft, it can cause tremor, it can cause weakness. If patients can get through that anxiety and nausea in the beginning, they tend to do relatively well. But long-term, we do see problems with decreased sexual interest and actual sexual dysfunction across the board. They're not interested in it. There can be arousal issues. There can be orgasm problems. So as the individuals are moving into adolescence and maybe exploring their sexuality, this could potentially be a problem for them. And then our venlafaxine, one of the new things with this one is if we get to higher doses, it actually can change blood pressure. So that would be something that wouldn't go away, that we would have to watch long term. So as you can see, there's some short-term things we need to worry about, but some long-term things as well. That's why it's so important we make sure that it's actually working for them. We're going to move to our next category. So Grady. Grady is a 16-year-old male. He is diagnosed with autism spectrum disorder and has been having some increasingly aggressive episodes. So they started him on an antipsychotic medication. Now, sometimes that description can be really intimidating for families, an antipsychotic, even though he's not psychotic. And as they start to look at the side effects, it can be even more intimidating. So we see those similar stomach issues and dizziness and potential sleep changes with these medicines. Most of them do tend to cause drowsiness, but in some instances we can see some insomnia where they're a little bit more aroused. Different with these medicines that I really wanted to make sure that we hit on, especially the newer agents, the ones that you see most commonly are second generations, they can cause some metabolic changes, increased appetite resulting in weight gain, increase in cholesterol levels, and there's a little star there. It actually can make the bad cholesterol go up and the good cholesterol go down. So it really creates a cholesterol profile that's not very advantageous for the patient. It puts them at risk for a lot of other complications medically. It also can increase their sugar levels where they can be diagnosed with diabetes. So these effects take some time to develop. So you can see the increase in appetite relatively soon, but the changes in weight, cholesterol, and sugar may take some time. So it's important that we're aware of these and that we're keeping track of them. The other big class of side effects that antipsychotics have are movement disorders. And I'm gonna move to the next slide. So movement disorders, some of them can happen right away, and some of them may happen a little bit later in therapy. So they can have something called dystonic reactions. Think about having a sustained muscle contraction. It can be really painful, especially if you're not expecting it. This can happen the first time that they get a medicine. It can happen when their medicine is increased, their dose is increased. It can be really painful, and if that happens, it is unlikely they're going to want to take that medicine. So it's important that we're aware of that and that we watch for that. These medicines can cause restlessness. It looks like agitation. In a patient like Grady, this could be a big problem. So if we're treating him for some aggressiveness and he gets more agitated and aggressive, we may want to increase the dose, and then that makes everything worse. So that's an important consideration to keep in mind. It blocks dopamine in the brain. Dopamine's involved with Parkinson's disease. So it can make the patients look like they have Parkinson's disease. They may have a tremor, they may have a slower walk, they may have some rigidity in their muscles. Their muscles aren't quite as compliant as they should be. They might be a little unsteady on their feet, unable to get their balance if they trip. So this is something that can happen a little bit later on, but that we'd want to be aware of because we don't want to put them at risk for falling. And then dyskinesias. So these are movements that can happen throughout the body. In some cases, it's abnormal movements in the face. So it could be squinting, it could be jaw movements, tongue movements. It could be kind of writhing a little bit. It might be in their arms where their arms are moving constantly, in their hands, in their fingers. Now this can be distinguishing for patients. It makes them a little bit uncomfortable. People may notice that they're making those movements. But one of the problems we had with the older antipsychotics is once patients got these, they didn't go away. So even if you took them off the medicine, it was permanent, and that was tardive dyskinesia. So it was those involuntary movements that were irreversible. So we tend to want to watch those pretty carefully. It's less likely to happen with our newer agents, but it can still happen. And again, that's not something that's going to happen right away. It's something that's going to happen a little bit later on. Last couple things, there are a couple other issues that we run into with our antipsychotic medications. It can affect the blood counts, both the red, white, and platelets. So make a patient anemic where they don't have a lot of energy, make it difficult for them to fight an infection if they don't have a lot of white blood cells, or make it a little more likely that they bleed or bruise a lot if their platelets are low. Not common, but it is a reason that we'd want to be cautious. These can cause some heart rhythm changes. And then similar to the serotonin agents in our antidepressants, if we're using the antipsychotics, sometimes patients can have what's called neuroleptic malignant syndrome. So this can be a really severe reaction where they need to seek medical care. So again, if we see any major changes in mental status, they increase the rigidity quite a bit. They develop a fever, they're tremulous. They might have blood pressure changes where they feel dizzy, they feel like their heart is racing. All of those things, we'd need them to seek immediate attention. Last class, George is actually, I made it the oldest one, but it's the itty bitty little dog that lives next door. He's constantly in our garage. He loves my dog. George is a 17-year-old male, recently diagnosed with bipolar disorder. And for treatment of his bipolar disorder, they decided to start him on a mood stabilizer. So with these, they're also used to treat seizures. We see similar buckets of side effects. So if we're trying to calm down the symptoms of bipolar disorder, trying to calm down the neurons for epilepsy, not a surprise that we see a lot of things like drowsiness. It can be lack of coordination, muscle coordination. Maybe they're not quite have the same amount of dexterity they had previously. And you can see some weakness as well with most of those medicines. Nausea and vomiting can happen with most of them. Interestingly, all of these medicines, the whole class carries a warning for suicidality, increased suicidal thoughts, developing a suicidal plan, or potentially attempting. And this is even in patients who have epilepsy that are on these medicines. So when we first start these medicines, again, watching those patients for an increase in those symptoms. For the different classes, these all work very differently. So there are some pretty significant expectations that we can have for each of them. For agents like the trileptal and the tegretol, the carbamazepine and oxcarbazepine, we can see a lot of blood type changes in their electrolytes like their sodium, their liver function. It may decrease their white blood cells so they can't fight off an infection, and they could develop a rash that could be potentially fatal. So in patients of Asian descent, we actually do genetic testing to see if they're at a greater risk for that. Lamotrigine, one of the bigger side effects of that one is that rash we just talked about, but that can happen with anyone. So if they develop that rash, it tends to happen earlier in treatment. We need to know, and they need to come off that right away. For our Depakote, the divalproex, that can cause some blood changes as well. We see low platelets, so they might bruise or bleed easier. We can see some liver toxicity. It might have some trouble with their pancreas. But patients can also gain weight and lose some of their hair, which can be really problematic, especially in adolescence. So George, who's 17, may not want to have those side effects right now, especially as maybe he's trying to develop a little bit more socially. So lots of side effect baggage to think about. And we do have a handful of contraindications, so reasons why we absolutely can't use some of these medicines. For our antidepressants, hypersensitivity, that's an allergy to the medicines. If they have an allergy to the medicine, a real allergy, we're not going to use that medicine again. So a rash, hives, if they have swelling in their throat or in their mouth where they have difficulty breathing, we're taking that off the table. If their side effect, if their allergy was nausea, I got nauseous when I took it, okay, that's not gonna be, we could potentially try that medicine again, maybe at a lower dose. Couple big things with the antidepressants. Other antidepressants that we've used, an old class of antidepressants, the MAOIs, we cannot use them within 14 days. So that's why sometimes the history is really important. It prevents the breakdown of dopamine, norepinephrine, and serotonin. So it increases the risk of things like that serotonin syndrome or problems with blood pressure. The bupropion has a couple other contraindications that are unique that I wanted to make sure we included. So it does increase the risk of developing seizures. So if a patient has a history of an eating disorder, a seizure disorder, or if they're withdrawing from a medicine or a substance like alcohol that increases the risk of seizures, this may make them seize, and it would not be appropriate in those patients. So narrows down who we can use it in. Our antipsychotics, again, those allergies, that hypersensitivity, we won't use it. Haloperidol, so this is one of our older agents. So in patients who have a lot of CNS depression, so maybe they're not completely coherent, this can actually make that worse and make it a little bit more difficult to be able to determine what's going on with them. So it may not be appropriate in those patients. For most of our new agents, we do have problems with those cardiac arrhythmias. Our Geodon in particular, we can't use it in patients that have any type of a heart history. So those would be patients that they're just not going to be a candidate because the risk of them having heart problems really offsets the potential benefit of that medicine. And then our last bucket is our mood stabilizers, so the allergy, hypersensitivity. For the carbamazepine, if patients already have some of those low blood counts, especially low white blood cells, we don't want to use it. If we wipe out their white blood cells, especially now, that would be really put them at a disadvantage to be able to fight off any infections. They also, that older class of antidepressants, the MAOIs, they can have a lot of side effects if they've been on that, so we can't use those together. And then it can cause a lot of drug interactions, so we got to use caution with those medications. The last medication is the Depakote, the divalproex. So this one can be hard on the liver. So if somebody has liver disease, if they have a mitochondrial disorder or a urea cycle disorder, they can have a lot of toxicity from this. And it can damage the fetus. So it's not a good candidate for women of childbearing age who are not on contraception. It can cause neural tubule defects, so problems with the baby before the mom even knows she's pregnant. So it would be best if we avoid it in those patients. So adverse effects, we can see them both acutely and long-term, and it is important that we keep track of those. And contraindications, there's going to be situations where maybe a medicine's a good match, but there's also times where it's not going to be a good match at all. I will stop my share and turn it back to you, boss.